get started. So the title of this article is Immediate versus Delayed Insertion of an Etonogestrel Releasing Implant at Medical Abortion, a randomized controlled equivalence trial. Of course, the first part of the article is the introduction, and the goal of the introduction is to show the audience the gap in knowledge, so the rationale for doing the study, and then to show exactly what they're planning to do and what their purpose was. So they start out by saying that the majority of first trimester abortions are medical. Many of the women having first trimester abortions have had prior abortions. 83% ovulate in the first cycle after an abortion. 15% have intercourse within a week after the medical abortion. And immediate post-abortion LARC is recommended to prevent repeat pregnancy. LARC is commonly provided immediately after surgical abortion, but delayed to follow-up visit after a medical abortion. They also go on to point that the WHO guidelines recommendation for immediate post-abortal contraception often are not followed because of concern for an interaction between the mifepristone and the progesterone implant, possibly adversely affecting abortion. Mifepristone is a progesterone receptor modulator, and there is another progesterone receptor modulator that's been shown to interact with the progestin-only pill desogestrel, and desogestrel happens to be a precursor to the progestin that's in the implant. And they also point out that the mifepristone has a maximum concentration within 1 hour in the serum. So the gap in knowledge that they point out is that there is scarce data to show or exclude a possible interaction or an impact on the efficacy of medical abortion following using an early implant. There are a few pilot studies, and there's one randomized controlled study, but in that randomized controlled study, there was unclear pregnancy dating at one of the sites, and there was unclear timing of when the implant was inserted. So for their study, the purpose was they had a primary outcome, and then they had several secondary outcomes. For their primary outcome, they wanted to compare immediate, which what they defined as 1 hour following the mifepristone, versus delayed, which was 2 to 4 weeks following mifepristone, of a implant placement on complete abortion rate. So they wanted to see whether there was any difference between whether doing early placement of an implant versus delayed placement of an implant affected the success of an abortion, medical abortion. And then their secondary outcomes were comparing complication rates, rates of insertions, acceptability of the timing of placing the implant, pregnancy and repeat abortion after 6 months of follow-up. In the introduction, it's always great to see a hypothesis as well. They did not have one specifically stated, but this is an equivalency study, so we can assume what that would be. Okay, so let's talk about the introduction. Anybody have some comments on about the introduction, about whether we think that the introduction adequately covers the background, the gap in knowledge, whether they state their purpose in a reasonable fashion, whether they state their comparison clearly, can you tell what their hypothesis is going to be? What do people think about this particular introduction? Does the idea of the study make sense to people?
Yeah, I think that this is yeah. So this is from CIRHT Hospital. The idea of the study actually is understandable. The background specified the gap in the knowledge when they stated that there is no clear information of whether the immediate would be either superior or inferior to the delayed insertion of the implant. So the purpose is clear, and the comparison we understand is the delayed insertion of implants. However, the hypothesis was not yet well stated and not very clear to us.
making the study an equivalent, I mean, an RCT that is equivalent, as they mentioned, does that impose that you shouldn't hypothesize on what you want when you're giving an intervention?
Yeah. Yeah. So I think that's a good point. I think in this case, because their primary outcome, I think it all depends on the primary outcome. And I think in this case, because they made the primary outcome be successful abortion, in that case, they probably didn't have a reason to think that one was going to be better than the other. They didn't think that putting the implant in early was going to hurt the abortion. If they had instead had a primary outcome of repeat abortions in 6 months, or an outcome of having a LARC in place 6 months later or something like that, then they may have chosen one as being preferable over the other. So I think it probably depended on the primary outcome that they chose, that they decided to do that. Yeah, I thought it was an interesting question that came up, that you could see coming up in a clinical scenario, and realizing that there is a way to answer that in the clinic that's not really too complicated a study, really, and could potentially have impact. Thank you for those comments. Those are great. So this was, as we were saying, was a randomized controlled equivalence trial. They followed the consort recommendations. The setting was the outpatient family planning clinics in Sweden and Scotland between 2013 2015. Population were English or Swedish speaking women that were less than 64 days pregnant, based on ultrasound, and they were opting for the implant. And they excluded women less than 18 years old, or who had contraindications to medical abortion or implant, and who had a miscarriage or a molar pregnancy. The randomization was done by third-party concealed, one-to-one randomized, with computer-generated blocks of 10. They had an uninvolved study nurse create opaque numbered envelopes. It was unblinded for ethical and practical reasons. The sites had access to patient records. They had permits from the agency that issues permits for clinical trials in the European Union. It was IRB approved. It was registered with clinicaltrials.com. For the immediate group, after the mifepristone 200 milligrams in clinic, they inserted with local anesthesia the implant 1 hour after the ingestion. And then they got vaginal misoprostol 800 micrograms 24 to 48 hours after the initial treatment. And there were some variations in what they did in Sweden and Scotland. In Sweden, they got a second dose of 400 micrograms if there was no bleeding within 3 hours. And in Scotland, they took the misoprostol in the clinic and went home. For the delayed group, the implant was placed by the nurse midwife at the follow-up visit. An interviewer administered the questionnaires about bleeding, pain, preference, complications, unscheduled visits. And then follow-up was in clinic with a urine pregnancy test, or via phone with a home urine pregnancy test 2 to 3 weeks after the mifepristone. And again, they pointed out the primary outcomes were to show equivalence between the two groups for successful completion of abortion without the need for surgical evacuation. So surgical evacuation was really what they were looking for. And they assessed this with 2 to 4 weeks follow-up by questionnaire and patient records. And then the secondary endpoints that we mentioned before. So what do people think about these methods? They sound appropriate, generalizable? Were the outcome measures ideal? What do you think about the methodology like randomization, blinding, efforts to reduce bias, their follow-up? What comments do people maybe have about the methods?
So we did this section on methodology, and we think in the settings where this was done, the method was appropriate. However, we don't know how can it be generalized to our because, for instance, some of the methods that were used, for example, the intervention was the implants immediately after mifepristone, which we don't have in our settings, and also the settings in Sweden. Here, they could even mifepristone and misoprostol at home. So this variation also we wanted to against the other methodology that said they gave misoprostol 800 microgram 24 hours to 24 to 48 hours after mifepristone. So we see this variation as a source of bias. And also, so maybe for...
Yeah, I can actually complete my colleague. Mm-hmm. We also praised against the study, the blinding, because we think the study was non-blinded, so which means that the study conductor actually knew the information about. It's actually even stated that they had even like information, their clinical information, so which actually could raise the bias. Let's say if someone has a relative or someone they didn't want to give the implant on the first hour, so maybe, I mean, it would actually raise sort of biases. So we actually thought that is one of the gaps that we could see. And the other thing is that, as my colleagues mentioned before, as these people, we had actually a question for the Swedish people, they could take misoprostol and or mifepristone at home. So our question was like, when did they get the implant? If their first dose was at home, how do they get the 1 hour implant for the immediate one? So those were the ideas we had.
There's still one more comment from the audience.
So the other point, when it comes to exclusion criteria, we can't exclude all the patients who presented with miscarriage because those are the patients we are having. It's very rare to see a patient who comes in here with a rare fetus who is looking for abortion services. If you go with those ones, you might spend more than a year with less than 10 patients. So that would make this study not really generalizable in this context.
So yeah. we still have another comment regarding that.
Can you also detail how make efforts to reduce bias?
Could I detail how to make efforts to reduce bias?
Yeah, so in that study, they don't clearly state how they made the effort to reduce the bias. For instance, right. It was unblinded, which is a risk of, which can increase the risk of bias. And they did not clearly tell us how they made effort to reduce this bias.
Yeah. Exactly.
So, Dr. Bonaventure, also from CIRHT-UM, so to reduce the effort to reduce the bias, I am wondering from the immediate implant and from delayed. So the midwife is the one who put the implant in the delayed group, but from the immediate group, there is no specification of the one who put the implant. From there, if there are different people who put the implants, it can be the bias because the counseling from the midwife, the doctors, they are probable they can be biased so that the result cannot be the same, the final.
Yes. Yeah, those are all really good points. And there are ways to add blinding to a study, even if you can't blind when you're putting them in. You can blind other people who are collecting outcome data or analyzing or other pieces of the study to make it more rigorous. But yeah, those are really very good points.
One more point, sorry. So because this section was was for our sites, actually we had a lot of discussion about it. So in their study, they say that for follow-up in clinic, some women were given full control of self-administration of both medication and also self-diagnosis or self-UPT, urinary pregnancy test. So, and they don't clearly state how they reduce the bias of women who may say it was negative or it was positive, because a woman can herself pretend to make it positive or negative. It is not well described in the methodology.
Some points actually also talked about the generalizability of the study, because in our context, we could, but it's very difficult to assume that we can tell all our clients to go home and tell us 3 weeks whether they have done their pregnancy test or not. So that's also another thing that we might actually put in our context, and probably don't seem that is something that we can just generalize that is possible in our context.
Yeah, great point. And you really bring up the how important it is to really standardize your procedures and make sure you're have control over the data you're collecting.
I had a two comments. One comment is about generalizability and the timing of waiting for an hour after giving them mifepristone before placing the implant. That seems like it would be a challenge in many clinical settings where women are not going to want to stay for that hour. My second comment is that the lack of blinding, I don't think could have any significant impact on the primary outcome, because either somebody's pregnancy is terminated or it's not. And that's not something that could be changed by knowing when the implant was placed. So I'm not sure, my opinion would be that that doesn't introduce any additional bias.
Thank you.
I also have something to add here. And what kind of bias are we talking about? They have done concealment allocation, computer-generated randomization. So these all decrease the risk of selection bias. But what they could have done better is probably the blinding of the outcome assessors. The one who assessed the completion of the procedure could have been blinded whether the insertion was immediate or delayed. That is one area where they could have done blinding. And my other comment was in the outcome. The outcome they defined as successful abortion, which is defined as termination without the need for surgical intervention. I think this speaks all for abortion-related studies, but some providers will try one cycle of medical methods, then go for a second or a third, and somehow decide, okay, now it's not working, let's do a surgical. Here it's not specified if it is after one method, after one cycle of medication abortion, or two methods, or two cycle or third cycle. So we don't actually know when they decided, okay, this is not working, let's resort to a surgical method. It's not specifically mentioned. Thank you.
Thank you. Thank you for all those great comments. Let's move to the statistics. So for the power analysis, they calculated that they would need 252 per group using 97% success of the abortion with two-sided margin of equivalence using minus 5% to 5% range for the difference between the two therapies in terms of success of or between a risk of needing to have a surgical completion of the abortion. Alpha 0.05 and power of 90%. And then their recruitment goal was 560 to account for loss to follow-up. And then they defined their populations that they were going to do for their statistical analyses. So for their intent to treat population, all women who consented, except those who withdrew before the abortion or insertion of the implant, were considered their intent to treat population. Their per protocol population were all women in the intent to treat analysis, except those who changed their mind about contraception before the insertion or who had the implant put in at the wrong delayed timing. And then for the primary analysis, they were performing this on their per protocol population. And then they were going to secondarily look at the intent to treat population, make sure that that analysis shows similar results. They also did a sensitivity analysis, which excluded all women in the per protocol population who did not come for follow-up. And then all other analyses were with the intent to treat population. And for their analyses, they did a general estimating equation model with binomial distribution. Treatment center was included as a random factor, and they used Fisher exact to look for differences between groups in categorical data, and Mann-Whitney U-test for to compare continuous variables between groups. Here are the things I thought we would talk about a little bit. Power analysis, does this seem reasonable? Does it account for drop-offs and the endpoints? Does the statistics plan address the questions that they're asking? And do they take into account the women that they're potentially excluding? That makes sense. So I'll just go ahead and comment a couple things. One thing is that for equivalency studies, generally the sample size tends to be fairly large because you're trying to show that two things are equivalent, and for the power calculations, you generally end up with fairly large sample sizes compared to studies when you are trying to show differences. One of the important things generally ends up being the margin of equivalence that you end up choosing. So that range that you're going to use to show that two things are similar. So in this case, they use that 5% that those two different therapies, either immediate or delayed placement of the implant, needed to be within 5% of each other. That's an important factor that has to be selected. And I will just comment that there is not any justification for that 5% mentioned in the paper that I could see. I think it sounds reasonable, but I didn't see any particular reason that that number was chosen. I think the 97% success of the abortion sounds reasonable too. But that 5% is an important number, whatever it is that's chosen for the equivalency number in the power calculation. So that's just something to think about in looking at these studies. And then I just also wanted to comment that my understanding about intent to treat populations is that you are supposed to include all the women that were initially randomized, regardless of what happens to them. and they were going to exclude women who withdrew before the abortion or before different things. And my understanding is that if you randomize them, you include them in the intent to treat population. So that was a little bit different than what my understanding is. Those are a couple of comments I was going to make.
So you're limiting the number of people that are included by getting rid of those people.
Yeah, you reduce it a little bit. Yeah, go off this one. So first of all, this is the consort flow chart that shows, I know these numbers are small, this is straight out of the paper. They had 551 randomized, 282 allocated to immediate insertion, 268 allocated to delayed insertion, and then they ended up with 277 that were analyzed in the immediate and 261 analyzed in the delayed because of some women who either withdrew or did not receive abortions. And then there were women who did not come for follow-up, so they did not follow the protocol, and so they were in that per protocol group in both sides. So you can see that's pretty similar, and the ones that did not come for follow-up is about 32 in one group and 34 in the other, so that ratio is pretty similar. They point out that there are no demographic differences between the two groups, so the average age is about 25, and the gestational age was similar, about 46 days. So for their primary outcome, again, they did their per protocol analysis, which was need for surgical intervention. It was 5.8% in the immediate group versus 4% in the delayed group. So that is within plus or minus 5%, and so that met the equivalency for their statistics. And then they also did the intent to treat analysis, and they got a similar result, and there were no serious adverse events related to the insertions. And I did not see the sensitivity analysis in their results section. For secondary outcomes, there were no serious adverse events. For unscheduled visits for problems, which were primarily bleeding and or pain, in the immediate it was 10%, delayed 6.5%, not statistically different. For extra dose of misoprostol needed, immediate was 6.8% versus delayed 3.4%. It was not different, but there was a trend. For did not attend follow-up visit, for immediate it was 31%, for delayed it was 24%. It was not different. For the insertion rate, immediate was 99%, delayed 71%. That was statistically different. And then for reasons for removal, for those who had it removed, the primary reason was bleeding. That was in, I guess, 7%. That was for both immediate and delayed. Primary reason was bleeding for those who had implants removed. In their secondary outcomes, they evaluated those who preferred the allocation time of insertion. There was a lot of missing data, but for immediate, 64.9% preferred the allocation time, and the delayed 19% preferred their allocation time, so that was significantly different. Satisfaction was higher in the immediate group at 3 months, but then there was no difference at 6 months. They looked at continued usage of the implant at 3 months. Again, there was a lot of missing data, but in those who had verified continued implant use in the immediate group, it was 80.9%, in the delayed group, 68.6%. So that was significantly different. For verified implant removal, immediate group is 6.5%, delayed 5.1%, no difference. For continued implant use at 6 months, again, a lot of missing data, but for immediate group, 71.8% versus delayed 57.9%, it was significantly different. And this is just from their data showing the very satisfied versus fairly satisfied. In the immediate group, it was different at 3 months, but then no difference at 6 months. And then their continued secondary outcomes, the cumulative removal rates were lower for the immediate insertion, continued implant use. Pregnancy rate at 6 months. In the immediate group, they had 2 versus delayed, they had 10. 1 resulted in a miscarriage, and the rest all ended in termination. In the immediate group, both were implant removals, and in the delayed, 1 was implant removal and 9 had not come for insertions. So, for the results, some of the things to discuss is the primary question answered by the research? And were the results presented in a way that was logical and understandable? And are there any other data or analyses that would enhance the research that was done?
The primary question was answered. It was in a good logical presentation, because you can ideally see exactly that the immediate insertion was not assigned with so much side effects. And when you look at the 3-month evaluation, people showed interest. I mean, people actually still kept the method for the 3 months, though the big number of the missing data. So it looked really logical.
I think what you were saying was that the primary outcome was well answered, and then with the missing data, some of the secondary outcomes were not as clear. I think that's what you were saying.
Scotland, where they have different regular implication variations, maybe they could still make analysis in regard to that and see whether they still have the same findings or if it is different. Because if someone went home with medications versus someone who need to come at the hospital for picking them, we might have differences.
And yeah, I agree with you. And the fact that if they didn't believe that the sites had different protocols and different tolerance for when they used extra doses and things like that, and women making those decisions at home and doing a lot of things at home. Very good point. Okay, so let's go to the discussion. So they start with a summary saying that they established equivalence for the impact of immediate insertion of an implant compared to delayed insertion. In the immediate group, the insertion rates were higher, more acceptable, and they had lower unintended pregnancy and abortion. And this allows for 1 visit for abortion and contraception. They compared their results to the literature and point out that in the literature, women prefer fewer visits for abortion in prior studies. LARC at the time of abortion is shown to reduce repeat abortion in multiple studies. Prior studies suggest immediate insertion does not affect the efficacy and resulted in higher insertion rates. And that there's a study with women up to 13 weeks estimated gestational age with 78 women that found that with immediate insertion, they were more likely to need repeat doses of misoprostol compared to delayed, and that their study did not have that. I mean, they had a trend, but they did not have that. In the Raymond study, they found that the timing, although the timing of their study, the insertion was not rigorous, they did not have a reduction in the unintended pregnancy, which was different than their study where they did have a reduction. They point out that the strengths are that their study should be more reproducible because they had a stringent protocol with ultrasound dating as well. It was multi-center design and size was large, so this should be more generalizable. And it shows that delayed insertion may result in no contraception at all. They point out the weaknesses, which are lost to follow-up, which has been mentioned, and that they mentioned that the centers had access to records for the entire region, and that they should have been able to identify complications and need for surgical treatment. They point out that the proportion of women who had lost to follow-up was equal between groups, and all of the analyses were the same overall. They do mention that their sensitivity analysis was similar to the other results in the discussion. So they summarize things by saying that they provided evidence for providing immediate implant at the time of medical abortion, and that although this was done in a high resource setting, it has relevance to all countries, and that it increases satisfaction and the number of women receiving the most effective post-abortal contraception, and subsequently preventing unintended pregnancy and abortion. So what do people think about the discussion? Is it appropriate literature comparison, appropriate interpretation of their results? Do they capture strengths and weaknesses of their study? Are their conclusions seem appropriate from their study? What do people think about this discussion?
Yeah, sure. I'm David. I'm a resident at University of Rwanda in Butare. About this study, I'm appraising it as it has a good number of participants, 500 they are enough. And as I have been following this study, there is really no difference between immediate and delayed use of that implanon. This is why in our setting, we need to apply this result from this study. And we are happy that in our setting, we have a trained midwife who is always rounding with doctors in the wards where there are patients who had had abortions, and they quit the hospital with implanon. But unfortunately, we are managing cases of abortions by misoprostol and sometimes by surgical management of evacuation from the uterus. We don't use we are not using mifepristone, and in that case, we always want to adapt to this study and use implanon right away after evacuation, or either after doing a control ultrasound and know that her uterus is already empty.
So, as my colleague from the south has stated some ideas about the topic. So, from the 4 questions that are displayed on the screen, if you can see the literature, actually they tried to look about some literature, but I don't think the literature was enough, and I don't think they also considered all settings, many settings. For instance, in case of our settings, and also interpretation was appropriate according to what literature they show that they have seen. So, but because they lacked some of the literatures, for instance, in in our context, or literature is not accessible, I don't know. So then, I don't know which comment you would put on this, if the interpretation was appropriate or not appropriate. But from the study questions, the outcome that we can see that there was a little more superior effect of immediate use of compared to the delayed, and also they show even the immediate is also good. They also interpreted as with late insertion, there is a high risk of no contraception at all. So, which is also a good point that we think also applies also to our setting. And for the conclusions, after they have concluded that this study was done in high settings, in developed settings, but it can be generalized to low and middle settings. So, which is probably good for instance, in case of Ethiopia, as my friends has stated, in Ethiopia where they use mifepristone, that could be appropriate. But for instance, in our did not be the same case, especially that for us telling the patient to go home is equal to sending the patient without treatment, like denying to treat somebody.
Yeah, I think one more point on the discussion. Actually, they were able to interpret that people that got immediate contraception, long-acting contraception, had fewer number of abortions, subsequent abortions, which actually is something that I feel it's important, because most of the patient clients in our context, they do not want to have post-abortion family planning because they feel like they are getting a lower chance of getting pregnant. So instead, if we use this study, it's actually showing us that a post-abortion family planning contraception is actually giving a chance to a fewer number of abortion, hence a more successful future pregnancies. So, which I think is a good point. I also echo the sentiments of my colleague that we could probably have been better if we had some other literature from our context, from the low and middle income countries, because it's specifically that this was done in the higher income countries, so of which, yes, generalizing would be ideal, but would make much effort if that is exactly, if we had let's say, studies from across the world.
Yeah. Great points. Okay.
May I add something, please? This is still CIRHT speaking. When we say resource-limited settings, we also understand that those are the settings where ultrasound is not always available. This study was done, and the gestational age was always calculated by ultrasound. So when we say we can generalize it, I think we need to take that into consideration, and maybe it's not really the raw resource settings. If we can have the ultrasound ready for that, it's already something advanced. Thank you.
Great. Well, thank you all for those great points. I think we covered the clinical context as well here, and I really appreciate everybody contributing and participating. It made it a lot of fun.
We have a couple of comments actually in the chat. What is the time difference to say early and late insertion?
To answer the question about the time difference for early versus late insertion, somebody asked that question, and it's on very right here. Immediate is 1 hour following mifepristone, and delayed was 2 to 4 weeks following mifepristone.
2 to 4 weeks.
4 weeks.
There was another one that this is a comment. The title is not clear. We cannot know what the researcher wanted to look for. Someone says, I would love to have the information about post-abortion care because this was purely medical. Another question, what is the best models used for such analysis? I think that's in relation to the statistical analysis. We've got another question about the sampling techniques utilized to say it's generalizable in low-income countries.
Dr. Yolanda, just a question.
Yeah. Yes.
Well, generally speaking about the whole article and how it was conducted. So, this is Dr. Diomed from CIRHT-UM.
Yep.
Hi, Dr. Diomed.
Hi.
Yeah, hi. So the question is, usually mifepristone is given to the patient. The patient goes home with misoprostol to be taken some hours, 36, 48 hours later. So, and normally the patient should come back for checkup, and this is a good time to discuss about future contraception. So how can we discuss with a contraception, somebody who is still pregnant and she's coming for abortion and you even don't know yet the outcome? I feel how ethical was the whole article, the whole study. Do you understand my point?
To talk about contraception while she's still pregnant?
Exactly, because we are trying to insert the implant on her. When she's still pregnant, she came to seek for abortion. You are providing abortion, you start the abortion procedure, and you are talking about the future contraception in the future. And we don't know yet, you don't know the outcome of this current pregnancy, if the evacuation is going to be successful, what about it? So why not talking about it when she comes back for checkup usually? Because usually we ask them to come back to see if really the uterus has been well evacuated. What do you think?
Well, the concern is that she may not come back, and I think they had lost to follow-up was like 30% or something did not come back. And so the concern is that it's an opportunity to educate and offer contraception while they're there at a time when they really may be very open to talking about it and address a future issue for them and handle it all in one visit.
For sure, but talking about biases, if I feel that you have provided me with everything, then I may not even come back to come and see you. Because if you give everything, you give me mifepristone, misoprostol, and the future contraception, then I may never come back to see you because I feel I have done everything. But if I feel that there is something remaining for me to, okay, then the follow-up or the loss will lower.
Yeah.
Need you.
Right, and they did have less follow-up in the people who got everything, but they still had a lot of loss of follow-up in the people who were supposed to come in for follow-up. So the people who, even signed up and committed to coming in, I think they had 24% loss to follow-up. I don't have it right in front of me. And those who got the implant had like 31% loss to follow-up. So it's a very large loss to follow-up either way, and the difference is not that much. It was only like a 5% difference, whether you put the implant in or didn't, in terms of loss to follow-up.
We also had a question about what is meant by equivalence trial.
Oh, equivalence trial is when you're trying to show that two things are similar rather than trying to show that one thing is better than the other. So those are less common trials.
How does the socio-demographic of the participants generalize to others? That is also something that we did discuss.
Yeah.
It's a good point.
Yeah. It's not clear how generalizable this is to every setting. Yeah.
And then what do you mean by large lost follow-up? Does it affect the whole study?
By loss to follow-up, we mean that they didn't come for their visit to the doctor's office after their termination, and or they didn't do their phone call follow-up.
Right.
That's in our comments. If it was addressed when they addressed the attrition bias, if that was also considered during the when they dealt with the bias, because we saw that as an attrition, but it's not clear again. Like we commented before, it's not clear again.
You stated that the finding to be generalized to lower income countries. So what sampling technique was used in this study?
The sampling technique, I believe they included everybody. They did not state a sampling technique. They included all women who presented to the clinics who met criteria. There was no sampling technique.
Okay. All right. I think that's about it. Thank you very much.
A lot of good points brought up in the questions. Thank you. Thank you.
Yeah.